Good evening, everyone. Today, I will try to discuss in brief about the clinical application of probiotics in the neonate. The brief overview of the presentation. First, I'll discuss a few definition in the historical perspective, then mechanism of protection and some physiological aspect of the intestinal microbiome. Then some role of probiotics and the prebiotics during pregnancy, and finally the probiotics role in term and also the preterm neonate. First, the probiotics. Probiotics are live microorganism when administered in adequate amount confer a health benefit to the host. Prebiotics are the exogenous product which contain substrate promoting colonization of the commensal organism. And the symbiotics is a combination product containing both probiotic and the prebiotic. With the history, the first concept of the useful microbiome is given by the Eli Mendikov in the 1907 on his landmark papers on the prolongation of the life. And the 1952, the first lactobacillus was administered to neonate to examine effect on weight gain, and the first randomized control trial of probiotics in neonate done in 1986, and the first large-scale study on the probiotic prevention of the NSE done in 1999, and the first meta-analysis for the use of probiotics to prevention of NSE was published in 2007. Coming to the mechanism of protection of the probiotics, it's act by various ways, like it enhances the gut barrier function for preventing the pathogenic bacterial migration by increasing production of mucus, secretory immunoglobulin, and other bioactive factors. They also decrease colonization with pathogenic microorganism and increase diversity by compete for the same space, binding site, and the nutrient as pathogenic microorganism. It also increases diversity and colonization with non-pathogenic microorganism by secreting antimicrobial peptide and the bacteriocin that inhibit growth of the other bacteria. It also modifies the host immune response or act by the toll-like receptor to modulate the production of cytokine and inhibit the apoptosis and stimulate cell regeneration. Finally, it also increases the enteric nervous system maturation by promoting gastrointestinal motility, which is the potential explanation for their beneficial effect in the prevention of NSE. Now coming to the physiological aspect of the intestinal microbiome. If you see the gut microbiota, it's a multitude of site-specific community of bacterial localized to the skin, mucosal surface, and in the intestinal tract. The prokaryotic component of the intestine that comprise nearly 10 to the 14 cells that weigh around 1 kg in the human adult. And there is also marked abnormal gradient of this microbiota. Like in jejunum, there is density is 10 to 20, 2 to 3, distal idiom is 10 to the 7, or the ascending clone is 10 to the 11. The composition of the gut microbial community was originally known through culture-based study, which estimated that around 400 to 500 different species are present in the adult human intestinal tract. But recent culture-independent analysis, the gut microbiota is thought to comprise about more than 1,000 bacterial species per individual, or over more than 5,000 species in total. The gut microbiota mainly dominated by the 4 phyla, that is the Actinobacteria, Firmicutes, Bacteroides, and the Proteobacteria. The function of the microbiota, it's modulate the intestinal inflammation, the immune function. The intestinal microbiota is a key regulatory checkpoint for the development of the adaptive immune system and also for the innate inflammatory response. The bioreactor function, the complex carbohydrate are poorly digested by the human digestive system. They require microbiota for breakdown or fermentation. The end product of this fermentation is some short chain fatty acid like acetate, propion, and butyrate. Its short chain fatty acid has multitude of functions like its epigenetic effect, also differentiating the growth promoting activity, immunomodulatory effect, it also affect on the interepithelial tight junction. They have also role in the intestinal development like epithelial proliferation, restitution, angiogenesis, also exclusive of the other pathogenic microbiota. Coming to the development of the intestinal microbiome, the dogma that fetus reside in the sterile environment and that the newborn only attains microbiota after exposure to the extra uterine environment is being effectively challenged. Study being non-culture based technique revealed the presence of microbes in the placenta, amniotic fluid, and also meconium. Taxonomy of these microbes differ depending on the stage of fetal maturity. The greater degree of prematurity is directly related to the bacterial DNA load in the amniotic fluid. It suggests that relationship between the preterm delivery and the microbial load. Amniotic fluid microbes are swallowed by the fetus. These microbes subsequently reach the highly immunoreactive fetal GI tract, where a fetal-derived inflammatory response syndrome inside an inflammatory response that led to premature liver and intestinal morbidity. The fetal maternal microbiome source, mainly from the food, is the maternal oral cavity, placenta, maternal intestine, and the vagina. Coming to the maternal microbiome change, which occur during the normal pregnancy. The vaginal microbiome changes from the first to third trimester of pregnancy. That is the overall decrease in the microbial diversity and shift toward the predominance of lactobacillus species. It's followed by the Clostridiales, Bacteroidetes, and Actinomycetes. The lactobacillus predominance appear to protect from bacterial pathogen by maintenance of the low vaginal pH through lactic acid production. Maternal gut microbiome decrease in individual diversity by the third trimester, marked by increased proteobacteria and actinobacteria, and decrease in Faecalibacterium. The beneficial to pregnancy by promoting this physiological insulin resistance that develop during typical pregnancy course. This insulin resistance fosters adequate energy transfer to the developing fetus and in its optimal fetal growth. The placental microbiome, the placenta maintains its own microbiome, which appeared to occupy a niche of separate from the maternal, vaginal, and the gut microbiome. These community most commonly correlate with the maternal oral microbiome, largely composed of the non-pathogenic commensal organisms like Firmicutes, Neonate, Proteobacteria, Bacteroides, and Fusobacteria. Variation of the placental microbiome may be seen with preterm birth, with increased abundance of the Actinomycetes and alpha-bacteria, and after a remote antenatal infection like increased Streptococcus and Acinetobacter species. Coming to dysbiosis in pregnancy, adverse health state during pregnancy may affect the intestinal microbiome change, like the overweight and excessive weight during pregnancy may lead to increased staphylococci, bacteroides, enterobacteriaceae, and clostridia, and reduce the intestinal bifidobacteria. And like maternal pregestational diabetes may increase higher prevalence of bacteroides, parabacteroides, and the Lacunospiraceae in the meconium. This decreased lactobacillus and the bifidobacteria species colonization during early infancy is associated with greater risks for allergy at the fiber of life, and also decreased bifidobacterial number and increased Staph aureus number in infancy may predict the childhood obesity. Maternal and or placental dysbiosis is a trigger for preterm labor also. Vaginal dysbiosis, bacterial vaginosis represent a marked state of vaginal dysbiosis associated with spontaneous abortion and the preterm labor. The oral dysbiosis, that is periodontal disease in pregnancy, is associated with the preterm labor and with low infant birth weight. Coming to the role of prebiotics and the probiotics during pregnancy. This is prebiotic during pregnancy. Prebiotic may alter the prenatal microbiome during pregnancy, can affect both health status of mother and the fetal outcome. In the animal study, the prebiotic supplementation during pregnancy show there is a weight gain, increased colonic length, muscle mass, increased bone mass, decreased allergy, and decreased asthma in the child, the later part of development. But the human study are limited. Supplementation with symbiotic has been shown to significantly decrease the serum insulin concentration in the woman. It also reduces the risk of preeclampsia and the dyslipidemia during pregnancy. What is the role of probiotic during pregnancy? The probiotic supplementation during pregnancy may have some protective role in the prevention of preeclampsia, vaginal infection, gestational diabetes, and also prevention of some childhood disease. Gestational diabetes first study linking the probiotics to improve glycemic control have been mixed. In an article by the randomized control trial by the Ilmonen et al., which include 256 healthy women, so that dietary intervention plus probiotics decrease the postpartum waist circumference and significantly reduce the incident gestational diabetes from 34 to 36% to only 13%. But another study by Linsky et al., which included 175 obese women, so that shorter 4-week administration of probiotics during early third trimester pregnancy did not improve the glycemic control. Preeclampsia, an appealing disease for target for probiotics, large prospective cohort study in Norway found that association between intake of milk product containing probiotic lactobacilli reduced risk of preeclampsia, which is most pronounced in the severe preeclampsia. And additionally, probiotics have been shown to decrease high sensitivity C-reactive protein, marker for inflammation, which is associated with adverse maternal condition like preeclampsia and gestational diabetes. Bacterial vaginosis is another target for probiotics. Supplementation with probiotic mixture in late pregnancy counteract the decrease the bifidobacterium, modulate the decreased anti-inflammatory cytokine like interleukin-4 and interleukin-10, and induce a decrease in pro-inflammatory cytokine. The meta-analysis by the Ottman et al. Show that 81% reduction in the genital infection with oral probiotics. In a cohort study in the Norway also demonstrated association between the high intake of probiotic dairy product and reduce risk of spontaneous preterm delivery. Probiotic supplementation in pregnancy also prevent some childhood disease like atopic dermatitis, eczema, rhinoconjunctivitis, and obesity. Coming to the role of probiotics in term neonate. In very early administration of probiotics from the gut microbiota is not fully established have some beneficial effect in terms of prevention of late development of some disease like acute viral gastroenteritis, prevention of antibiotic-associated diarrhea, infantile colic, reduction of IBD, and allergic disorder. Infantile colic, the impact of probiotic administration for the treatment of infant colic has been subject of several randomized clinical trials. In a meta-analysis which includes 6 studies of the lactobacillus reuteri demonstrated significant improvement with mean decrease in crying time of 56 minutes per day in infant receiving the probiotic. Another study, there is a symbiotic combination with fructooligosaccharides and the 7 probiotic bacteria also demonstrates significant improvement in colic symptom compared to placebo. Allergic disorder, the prevention of allergy through such early administration of probiotics is appealing, but the evidence of their effect is conflicting. Administration of lactobacillus GG to a mother during pregnancy and the breastfeeding appeared to be safe and effective method for enhancing the immunoprotective potential of breast milk and preventing atopic eczema in infant. And the lactobacillus reuteri supplementation in infant with family history allergic disease did not confirm a preventive effect against infant eczema, but found a decreased prevalence of IgE-associated eczema during second year of life. Infant receiving lactobacillus rhamnosus are significantly lower risk of eczema than infant receiving the placebo, but this was not the case for Bacillus animalis lactis, and there was no significant effect this two strain on the effect on atopy. This discrepancy between the observed effect could be linked to the various probiotic strain use. Indeed, the mechanism of their action could be through the maturation of the immune system. So, Spec and Nutrition Committee conclude that there is too much uncertainty to draw a reliable conclusion on the existing study, but the Cochrane database review claimed that there is a possible load of probiotics intervention prevention of atopic dermatitis. This promising result associated with the fact that the impact on the immune system has been shown to be strain dependent, highlighting the importance of the choice of probiotic strain and argue for further study in this field. Obesity, the intestinal microbiota may contribute to the development of the inflammation and the insulin resistance leading to overweight and obesity, either by its role in the regulation of energy homeostasis and the food storage, or by the chronic inflammation it could induce, or both. The finding of early difference in microbiota of infants who later become overweight or obese argue for an early intervention. In a randomized controlled trial by Lotte et al., which included 159 pregnant women, they saw this parenteral probiotic administration appeared to be moderate the initial phase of excessive weight gain, especially among the children who later become overweight. But for the second phase of excessive weight gain, the impact being the most pronounced the first at the age of 4 years. In another study by the Gobel et al., they did a study, a control trial, performed children between day 12 and day 15 of age over the 2-week period. The probiotic used lactobacillus salivarius, and the objective was to investigate the effect of the probiotic supplementation on the marker of inflammation and the metabolic syndrome that show that no beneficial effect on this marker of the probiotic supplementation. Now coming to the probiotics in the preterm neonate. Before going details, there is some peculiarity of the gut bacterial stabilization of the preterm neonates. We all know that is bifidobacteria and the lactobacilli are the dominant bacteria in term infant, but the preterm infant experiences a delayed and abnormal pattern of gut colonization. The fecal microbiota preterm infant is common with staphylococci because of the predominant species in the ICU, Clostridia, most common anaerobe during the first week of life, Enterobacteria and Enterococci, slightly delayed colonization, and the bifidobacteria seldom colonize in the preterm neonate. So this bacterial establishment in the expression of colonization from the environment rather than the maternal origin. This abnormal pattern colonization may be due to more frequent birth through cesarean section in case of preterm baby, large antibiotic use, delayed initiation of enteral feeding, and exposure to unusual microorganisms that populate in the NICU. This premature infant intestinal dysbiosis appear to be an important ticket for sepsis, NAC, and also some late onset disease. The role of probiotics mainly and preterm baby mainly is prevention of NAC, also promoting the feeding tolerance, also prevent the late onset sepsis and fungal sepsis, also improve the neurodevelopmental outcome. First is probiotics for preventing NAC. By far the most compelling indication for the use of probiotics in the preterm infant is the prevention of NEC. The numerous systematic review and meta-analysis of the randomized control trial involving more than 10,000 neonates show that probiotics significantly reduce both risks of moderate to severe NEC and mortality. But among the randomized control trial of probiotics, there is significant heterogeneity in the study criteria with regard to probiotic species, single versus multiple species, dose, time of initiation, duration, type of feed, like human milk versus formula versus combination of both. Some meta-analysis on the probiotic done in premature infant. Now coming to a few details about some of the meta-analysis. Like for the first meta-analysis by the Al-Faleh and Anablis et al. In 2014, it includes 17 RCT, around 5,000 participants, and show the significant reduction of severe NAC among the VLBW infant with probiotic group with RR is 0.41, 95%, CI is 0.31 to 0.56. In a subgroup analysis of only high quality RCTs, including 11 RCT, demonstrated significant finding in the reduction of the severe NAC in the probiotic group with a 95% CI 0.31 to 0.59. The second meta-analysis of the Soito in 2016, it's include 38 RCT with around 10,000 patients. They show the significant reduction of severe NAC in the premature infant receiving the probiotics. Also, subgroup analysis of the VLBW infant which included 29 trial, around 9,000 patients. Nevertheless, an important finding in the Soito trial was that probiotics were not effective in reducing the risks of severe NAC in extremely low birth weight baby, which include the 6th trial, around 15,000 participants. Next meta-analysis by the Australian et al. In 2016. It's included 12 study, around 10,000 plus premature baby, reveal a significant reduction in the incidence of NAC in the probiotic group with the RR is 0.55, 95% stage 0.39 to 0.78. Now coming to the question, which probiotic strain should be used? In a phone survey in USA, there is 16 commercial probiotic products found to be used in the 70 centers across the USA, out of which only 4 products has undergone clinical trial. Therefore, As of 2015, 90% of the probiotics marketed in the USA not been evaluated for safety or efficacy in the preterm neonate. The most common type of probiotic used throughout all country is the bifidobacterium and the lactobacillus rhamnosus. The bifidobacterium infantil is the most popular. If you look in the United States, it is in 4 study as a multiple strain combination and 1 study single strain. And lactobacillus rhamnosus is the most popular in European country. It uses a single strain 5 study and a part of multi-strain 2 study. The most existing meta-analysis failed to account for strain-specific effect. The strain that significantly reduce the risk of NAC like Bifidobacterium lactis, Lactobacillus reuteri, and Lactobacillus rhamnosus GG. These combination strain that have been found to significantly reduce the risk of NAC like combination Bifidobacterium bifidum, infantis, longa, and the Lactobacillus acidophilus combination. Another combination is the Bifidobacterium infantilis and the Lactobacillus acidophilus. Other combination like Bifidobacterium longa and the Lactobacillus rhamnosus GG. So in multiple meta-analysis, multi-species probiotic supplementation was associated with greater reduction of incidence of severe NAC and the mortality. When comparing the species, the lactobacillus and the bifidobacterium species are found to confer most benefit. In summary, probiotics are used clinically for the BLBW infant. A multi-species probiotic supplementation containing both the lactobacillus and the bifidobacterium species should be recommended. Now coming to the timing of initiation, duration, and the dosage of probiotic. The most common criteria used for timing of initiation are within 48 hours. Some study use after 48 hours or with the first feed. Duration is a range from 4 to 6 weeks or until discharge. The most common dose is 1 billion chlorine unit per daily, with 6 billion being the second most common dose. The highest dose can be used as 12 billion chlorine unit per daily. Now, second benefit is a probiotic promoting the feeding tolerance and the time to achieve full enteral feed. It's shown that probiotic supplementation decrease the time to full enteral feed among the infant fed on exclusive human milk diet. In a randomized controlled trial, the probiotics promoting feeding tolerance in the preterm neonate include 104 infants. That show the no statistically significant difference in the primary outcome time to reach full feed at 11.2 days compared to 12.7 days with p-values 0.4. The finding of the Cochrane review in the meta-analysis by Alpha and Ambridge et al. In 2014 that the time to full enteral feed is lower the probiotic group is 1.32 days in the probiotic group compared to control groups. In another meta-analysis, which includes 5 studies, exclusively human milk feed infant receiving probiotic supplementation reached full enteral feed 3 days sooner than did control group receiving exclusive human milk feed without probiotic supplementation. Now, probiotics for prevention of late onset bacterial sepsis. The evidence that the probiotic may reduce late onset sepsis is controversial. Some studies may show that it did not reduction late onset sepsis in the probiotic group compared to the control group. Other study shows significant reduction of late onset sepsis in the probiotic group, but not in the LBW and BLBW category, but not in LBW category. So the probiotic may have some beneficial effect in reducing late onset sepsis in BLBW infant, but not in LBW infant. The role of probiotics in prevention of fungal sepsis. If you see the incidence of fungal sepsis in the BLBW infant is around 1 to 4%, LBW and 2 to 8%, in IMW is around 20%. In animal model, so this probiotic administration may reduce the fungal infection by the comparative inhibition, augmentation of guard period, enhancement of the immune function, production of hydrogen peroxide. In a systematic review and the meta-analysis of the effect of the probiotics on fungal colonization and sepsis, who et al. Reported that prophylactic probiotic supplementation had no effect on invasive fungal infection, but was associated with the lower risk of candida colonization. In another meta-analysis of the probiotic for the prevention of NAC, the risk of fungal sepsis was not affected with probiotic supplementation. So in summary, probiotics have had no effect on the risk of invasive fungal infection. The role of probiotics in the neurodevelopment outcome. It has been hypothesized that probiotic may improve neurodevelopment outcome by increasing production of the anti-inflammatory factor like TGF-beta, interleukin 4, 6, 13 against the inflammatory marker produced by the NSP susceptibility IVH. Other proposed mechanism like improve the feeding tolerance, improve the growth of the baby, and decrease the hospital industry. No study has specifically evaluated the effect of probiotic on the neurodevelopmental outcome. A secondary analysis of the pre-randomized controlled trial of probiotic for the prevention of NSC suggests that probiotic have no effect on the neurodevelopmental outcome in the preterm infant at 18 to 24 months. But the study was not powered to assess this outcome. Small sample size and use of single probiotic strain as well as complex multiple factors affecting the neurodevelopmental outcome cited as a result of finding no effect or lack of effect of probiotic on neurodevelopmental outcome in study. Now coming to safety of the probiotic, the safety of the probiotics is a valid concern since there is a lack of federal regulation of the quality and purity. It has been raised that the safety probiotics, sepsis, contamination probiotic formulation with pathogenic microorganism, altered probiotic altered the immune response. It also development of the and transfer of the antimicrobial resistance also may lead to allergic sensitization. One of the big steps caused with supplemental organism, the probiotic product. The major concern currently limited the routine use of probiotic in the neonate. Although no randomized controlled trial or meta-analysis have reported bacteremia or sepsis with the organism probiotic product, this has to be interpreted with the caution because many organisms in this product do not grow in aerobic culture, but instead require an anaerobic culture method. Typically, the aerobic culture method used for neonate, which may underestimate the true incidence of probiotic bacteria or sepsis. There are some case reports which confirm that probiotic associated with bacterial sepsis, like the Saccharomyces cerevisiae pangemia, is reported in 7 cases associated with probiotic supplementation containing Saccharomyces boulardii, Bifidobacterium longum bacteremia. It's reported in 3 cases and 290 elbrumine several probiotics for prevention of NSC. A few cases report of Bifidobacterium brevibacteremia. Coming to the contamination of probiotic formulation with pathogenic organism, the contamination of probiotic formulation with pathogenic organism remain a concern. This was validated in 2015 when an infant died of gastrointestinal mucormycosis after receiving a probiotic supplement found to be contaminated with Rhizopus oryzae, which is also isolated from his intestine. Another source of concern in the United States is that most available probiotics are produced and regulated as a food supplement rather than a pharmaceutical product. It altered the immune response, strain-specific alteration in the immune response by the T helper 1 cell, T helper 2 cell, enterocyte secreting cytokine CD8 cells in the enterolymph node and the spleen have been demonstrated. Presumably, the probiotics are altering the immune response in a beneficial way, but some effect may only be seen during large-scale and or long-term use, necessitating the ongoing surveillance and the reporting. Antimicrobial resistance. It's well known that the interspecies transfer of antimicrobial resistance occur when administering a live organism to patient. Therefore, it is logical to be concerned that the administered organism may be capable of transferring resistance to more virulent pathogens. This transfer, while rare, has been demonstrated and remain a concern. So, in summary, sepsis due to probiotic organism is very rare, but information on its occurrence is limited by the lack of systematic reporting and the positive information on culture method used to evaluate the suspected sepsis. However, the probiotic organisms are weakly virulent and the antibiotic sensitive, generally making infection not only rare but also easily treatable. Now, come to a few points of the prebiotics and the symbiotics. Prebiotics, as you all know, it's exogenous product. It's containing substrate promoting colonization of the combination organism. Human milk contains the prebiotic substrate called the human main oligosaccharide, which arrived at the intestine undigested. How does mechanism of protection of the prebiotics? That is, the prebiotics, the oligosaccharide resemble the carbohydrate binding structure used by the pathogenic organism and thereby inhibit adhesion and the invasion by this enteric pathogen. It's also serving as a primary carbon source for the commensal bifidobacterium species present in the intestinal neonate intestine. And the probiotic organism digests the oligosaccharide to short chain fatty acid, which serve an energy source for the intestinal epithelial cell and strengthen the intestinal barrier. The commercially prepared prebiotic component either contain the galacto-oligosaccharide and the fructo-oligosaccharide. A few studies examine the health benefit of prebiotic in unit in a meta-analysis, which include in 7 randomized controlled trial around 4,000 babies. They found that prebiotic was associated with some physiological changes such as decreased stool pH, stool viscosity, and the gastrointestinal transit time. The bifidobacteria species growth from the stool sample is also increased with the use of prebiotics, but there are no difference in the clinical outcome like NSA, late onset sepsis, time to reach full enteral feed. Symbiotics is a combination product on both probiotic culture and the prebiotic substrate. There is a limited study done on Neonate about the role of symbiotics. The results have been conflicting, but some synergistic effect of the modulation of inflammatory marker have been seen in the animal model of the NSC. The 3 recent clinical trials which examined the symbiotics and neonate in a single center RCT in South India included 220 infants receiving the breast milk show a decreased incidence of NSC with the administration of the product called lactobacillus, bifidobacterium, and the fructo-oligosaccharide compared to placebo. Another RCT also from South India compared the around 100 infants, the control group with the 100 infants receiving the fructo-oligosaccharide as well as the lactobacillus as well as bifidobacterium longum and bifidobacterium bifidum and streptococcus culture. Then receiving the multi-strain symbiotic product had a decreased incidence and severity of NSC compared to control group. In a multi-center randomized controlled trial team, this randomized around 400 available infant controlled on a 3 stadium that administered bifidobacterium lactis in a urine, the prebiotic oligosaccharide or both. The incidence of NSC was lower in the probiotic and the symbiotic group, but not the prebiotic group compared to control. Other outcomes improved in all 3 treatment groups compared to control. Both probiotic and the symbiotic were effective in this trial, but there was no additive effect of symbiotic compared to probiotic alone. So summary of this presentation based on the multiple randomized controlled trials and meta-analysis, the beneficial effect of probiotics given to VLW infant for the prevention of NSC and the decrease of all-cause mortality have been established. Nonetheless, the sole clinical report published by the American Academy of Pediatrics on probiotic use does not recommend routine use of probiotic in this population. The report stated that more study are needed. The 8th edition guideline for perinatal care published by AAP and the American College of Obstetrics and Gynecologists, there is no recommendation on the use of probiotics. Therefore, the use of probiotic in this population cannot be yet considered as a standard of care. The more research needed to assess the risks and benefit of this substrate, as well as to examine the most effective doses, formulation, and the duration. Thank you all.
Thank you, Habib, for comprehensive review of probiotics, prebiotics, and symbiotics. Have carefully discussed the physiology, clinical benefits, and with evidences. Now it is open for discussions.
With one question chat box, any commercial brand name of probiotics specially made for neonate?
Hello? Hello, what is the question?
Any commercial brand name of probiotics, especially made for neonates?